All right. Good morning, everyone. My name is Sylvia Soltis, and I'm the Pro Bono Director at Legal Aid. Thank you for joining us for today's Medicare Part D training. I'm joined today by my colleagues, Andrew Patterson, a senior staff attorney in Legal Aid's Public Benefits Unit, Jess Davis Ricci, a staff attorney in Whitman Walker's Legal Services Department. It's hard to believe, but this is our 17th year doing this Medicare Part D project. Whether you have been with us since the very beginning or this is your very first Medicare Part D season, we're grateful to have you with us and sharing your time. Simply put, our organizations could not do this work without your help. So thank you for making time to make sure our clients are in the best plans for the coming year. A few quick housekeeping items. We are recording this training and we'll share the recording before the end of the week. If you have questions throughout the training, you are more than welcome to type them into the chat or the Q&A box. We'll answer all the questions at the end of the training. So we thank you for your patience. I'm also going to pop back on at the very end to discuss next steps for both of our organizations. We have different processes, and it's helpful to understand how things will move forward after the training and in regards to your client assignments. We have a lot to cover today. So all that said, I'm going to now turn it over to Andrew Patterson, who will help us dive right in. Thanks, Andrew.
Thank you, Sylvia, and thank you, Jess, for joining. And thank you, everyone who is participating in the training. I'm just going to go ahead and get started because, as Sylvia said, we do have quite a bit to cover today. I'm going to make sure I can, there we go. So in terms of the overview of today's training, we're going to talk about Medicare Part D, the counseling process. We're going to go over just kind of at a very broad level what are Medicare, Medicaid, QMB, also called QIMB, and the low-income subsidy. We're going to talk about how to use Medicare.gov to analyze clients' prescription drug plans, and then we will wrap up, answer any questions, and as Sylvia said, she'll come back and talk about next steps. So I'm going to do the first part of the training, which is the overview. I will then turn it over to Jess, who will handle walking folks through the online protocol for how to do the enrollments. So at a very broad level, and again, folks who have done this before are going to be generally familiar with this, but what is Medicare? Medicare is a federal public health insurance program. It consists of various parts. So Part A is hospital insurance. That's insurance for care that is delivered while someone is an inpatient at a hospital. Part B is medical insurance. That's for kind of primary care, outpatient care. Medicare Part B does have a premium for 2024. I believe the premium will be around $174.80 per month. And that can go up depending on someone's income. Medicare Part C is Medicare Advantage. That is essentially a privatized version of Medicare Part A and B. And a lot of Medicare Part C plans also offer a prescription drug benefit, which is what Medicare Part D is. I'll just quickly note that over the past few years, I do think we've been seeing more people enrolled in Medicare Part C plans. And, you know, some of them actually have a fine experience with the Medicare Part C and the analysis, you know, people can still look and check and see whether someone's drugs will be covered for the next year through the Medicare.gov plan finder, even if they are enrolled in a Medicare Part C plan. And then there's Medicare Part D, which has historically been the focus of this training, which is the section of Medicare that provides standalone prescription drug benefits. Unlike Medicare Part A and B, which are fee-for-service and administered directly by CMS, Medicare Part D is a series of private drug plans that each differ by cost and by which drugs they cover. How does Medicare Part D work? So as I said, Medicare Part D is a series of private plans. Those plans change every year from year to year in terms of which plans are available and what they cover. In 2024, that should say 2024, there are going to be 19 standalone plans in Washington, D.C., And 4 of those will be low-income subsidy or no premium plans for low-income beneficiaries. And almost all, or virtually all, of the clients that we assist through this project do qualify for some kind of low-income cost-sharing assistance. The annual open enrollment for Medicare Part D is between October 15th and December 7th of each year. Any plan change made during that period is going to be effective January 1st of the following year. So in this case, the plan changes that are made during the open enrollment are effective January 1st, 2024. Most people broadly enrolled in Medicare can only switch their plans during this open enrollment, except for a few exceptions. We will talk a little bit later in the training about how low-income beneficiaries do have a little bit more freedom to change their plans throughout the course of the year. But for the most part, people are limited to changing their Medicare Part D plan or their Part C plan to this open enrollment period. This does overlap a little bit with the ACA's open enrollment season. Those dates are on the PowerPoint, and we just like to include that in case people have any questions or get confused about the open enrollment period. The relevant open enrollment period for Medicare Part D is the October 15th to December 7th period. And as I mentioned, there are subsidies for low-income beneficiaries, and there are some additional privileges that those low-income beneficiaries are able to use in terms of switching their plans outside of the open enrollment season. So what is the low-income subsidy? Sometimes you'll also hear this referred to as extra help. This is financial assistance for paying the cost of Medicare Part D. People who are enrolled in the low-income subsidy, if they are also enrolled in a low-income subsidy plan, will pay no premium, they have no deductible, and they will also have essentially no donut hole. Now, I think the donut hole has already been kind of closed over the past few years, but it used to be a sort of coverage gap, depending on the total amount spent on medications, where people would pay a much higher percentage of their medication cost. But that is closed for people who are enrolled in the low-income subsidy. People who are enrolled in the low-income subsidy also pay lower copays for their drugs. There are a couple of different levels of assistance in the low-income subsidy, but for 2024, the copays will be either $1.55 for generic or $4.60 for generic drugs, or $4.50 or $11.20 for brand name drugs, depending on the level of assistance that people receive. A handful of medications will also have zero copays. Whether a medication has a zero copay tends to vary from plan to plan. And there are also $0 in copayments after $8,000 of cost, after the cost of someone's medications for the year reaches $8,000. That's widely referred to as the catastrophic coverage phase. In addition to the low-income subsidy, there are a couple of other programs that a lot of our beneficiaries are going to be enrolled in. So I just talked about Extra Help, the low-income subsidy. That is by itself a federal program administered through the Social Security Administration. And as I said, it pays entirely or it lowers the Part D premiums. So, there are a handful of plans that are not low-income subsidy, but the low-income subsidy will still lower the premium that someone has to pay, even if there is an out-of-pocket premium. And I went over the lower copays that people will pay for each medication at the pharmacy. In Washington, D.C., very, very few, if any, people have to apply directly for the low-income subsidy program. That is because in Washington, D.C., there is a separate benefit called the QMB, or Qualified Medicare Beneficiary, also called QMB benefit, which is a Medicare savings program. The QMB benefit has some benefits that go beyond the low-income subsidy, but people who are enrolled in QMB in Washington, D.C. are automatically enrolled into the low-income subsidy. So people who have QMB in DC do not have to separately apply for the low-income subsidy through Social Security. QMB is a Medicaid-funded program, but is administered locally like Medicaid programs are, and people in Washington, D.C. apply through the D.C. Economic Security Administration. As I said, people in QMB, they get all of the benefits of the low income subsidy program, but they also get some additional benefits. The QMB program will pay a person's Medicare Part B premium, and it also eliminates co-pays and deductibles for Medicare covered services. So as I said, there's a $175 per month Medicare Part B premium. QMB will pay that. It will also pay for all the co-insurance and co-payments. So QMB saves people in DC who qualify a lot of money. And QMB, I think DC has maybe the highest income limit for QMB in the entire country. It's 300% of the federal poverty level. So it's a very generous program, and a lot of people benefit from this. A couple of things it does not do, however, it does not pay for any services that are not covered by Medicare. QMB is a Medicare cost-sharing program. It is not a standalone health insurance program. So if something is not covered by Medicare, QMB does not let that person get that benefit. And it does not pay for medications that are excluded from the Medicare formulary. Again, that's because it's a wraparound cost-sharing program for Medicare. It's not its own separate program with separate benefits. In addition to QMB, there are some people in Washington, D.C. with Medicare who also qualify for full Medicaid coverage. The income limit for full Medicaid for people with Medicare is substantially lower than the income limit for QMB. So I said the income limit for QMB is 300% of the federal poverty level. For full Medicaid, for most of the population, the income limit is 100% of the federal poverty level. But someone who has Medicare, who also gets enrolled in full Medicaid, and again, they would also apply through the DC Economic Security Administration, they will automatically get the low income subsidy, and they will automatically get QMB. So they don't have to apply separately for LIS or QMB if people who have Medicare also get enrolled in full Medicaid. And just so you know, you might hear this term thrown around, people who enroll in full Medicaid, we tend to refer to as dual eligibles or duals. So in addition to LIS and QMB, Medicaid pays for Medicaid covered services after Medicare pays, or services that Medicare does not pay for at all. Medicare does pay for a lot of health services, and for anything that is covered by both Medicare and Medicaid, Medicare is the primary payer or payer of first resort. But there are a handful of things that Medicare does not pay for that Medicaid does. Two specific examples of that in DC are dental benefits. The DC Medicaid program has a very comprehensive dental benefit, whereas the Medicare standalone Medicare A and B does not have a dental plan. And also home health care services. DC Medicaid has a much more robust home health service program than Medicare does. And there are a handful of drugs that Medicaid may pay for if they are excluded from the Medicare formulary. So those are the three different tiers of financial assistance that people with Medicare in DC can get depending on their income. So how do we assist Medicare beneficiaries with their drug needs in 2024? We confirm their current and future enrollment in either LIS, Medicaid, or QMB. We help them log in and assess what their current Medicare drug coverage is. We analyze their plans for 2024 to see what will be the best plan. Maybe it's the plan they're in, maybe it's a different plan. If it is beneficial to change, we will enroll the Medicare enrollee into a new Part D plan online. We could also do it by telephone, but generally we do it online through the Medicare.gov plan finder tool. And then in consultation with your mentor, help advise clients who are in plans that are not working, but who also may not be able to change plans at this time, or maybe there's not a good other option. There are some things that we can do in those situations, at least in terms of providing advice to help people with their plans, or with their medications, I should say. So I'm actually going to skip over the next few slides. The next few slides talk about creating a mymedicare.gov account. mymedicare.gov was new several years ago, and we had a big push to create accounts for all of the people that we assisted with. By and large now, I think the vast majority of people that we assist through this project already have mymedicare.gov accounts. If you happen to encounter someone who does not have a MyMedicare.gov account, you can talk to your mentor through Legal Aid or Whitman Walker, and they will be happy to assist you with that process. But I think it's very unlikely that this will come up for the vast majority of people this year. So I'm going to skip those slides. And instead, what I'm going to do is talk about how to conduct a general search in Medicare.gov. So the personalized search that someone can use when they have a MyMedicare.gov account, that's how you do sort of the personal search, where you see what plan that person is enrolled in, what medications they've been taking, and you can do that kind of personalized analysis for 2024. If someone doesn't have a MyMedicare.gov account, perhaps they don't want to create one, or if they're having trouble logging in to their MyMedicare.gov account, you can still do an analysis for that person by doing the general search. And there's a couple of screenshots in a minute that'll kind of walk you through how to do that. But there's a way essentially to continue without logging in. Doing a general search, you do need to have a little bit of information about the client's prescription drug needs. Obviously, you need to have their list of medications because you will have to enter that list of medications manually. There will not be the personalized information that you will be able to access through MyMedicare.gov. And then you would also need to put in the correct information to ensure that you are reflecting whatever level of low-income subsidy or cost sharing, whether it's QIMBY or full Medicaid, that person has, so that you can give them an accurate recommendation about what drug plans will cost for 2024. And as it says at the bottom, you can use this general search process if the login fails, or if the sometimes you can log in, but maybe there's confusion or it doesn't reflect someone's correct LIS or QIMBY status. And so you can use the generalized search for that purpose as well, to get a more accurate sense of what their costs will be for next year. In order to conduct a generalized search, this is a screenshot of the kind of login page on MyMedicare.gov. On the left, you will see that that's how you would log in for someone with a MyMedicare.gov, but on the right, you can continue without logging in. You'll want to select the year that you are doing coverage for or doing an analysis for. In this case, it would be 2024, and then you'll enter the zip code for the person who you're assisting. When you're conducting a general search, the other thing that you would need to do is to, again, like I said, make sure that you input the correct amount of extra help or low-income subsidy or QMB that person is receiving. So if that person has QMB, and I think that's not on this, I'm sorry. But if the person has QMB, there will be an option to select the Medicare Savings Program before you continue on. If the client has QMB and full DC Medicaid, then there's an option to select Medicaid. If the client happens to get SSI, which is a disability benefit through Social Security, that's supplemental security income, there's also an option to select supplemental security income as the extra help that person receives. If you are trying to do a generalized search and you have any questions about this, or you're not sure which one of these to select, that is an excellent time to speak to your mentor, because they can certainly help walk you through that and help figure out the best way to run a generalized search for the client you're assisting. After that, you will be at the same spot in the plan finder as you would in the search. You'll have to enter someone's medications. You'll have to select which pharmacy they use, and then it will send you on to all of the plans for 2024 and let you compare and contrast what those options are. So this is just kind of an overview of all of the different ways in which Medicare Part D enrollees who do not receive extra help, all of the different costs that are associated with Part D coverage. First, there is a premium for every Medicare Part D drug plan. In 2024, in DC, those will range from a minimum of 40 cents per month to a maximum of $113.40 per month. There will be a benchmark of $41.29. The Medicare Part D premium benchmark is the amount that sets where a plan is considered to be low-income subsidy plan. So A plan with a Medicare premium less than this benchmark is generally considered to be low income subsidy, although there's a couple of little exceptions to that. So if someone is enrolled in a plan with a subsidy, with a premium over $41.29, even if they are enrolled in the low income subsidy, they will still have to pay the difference between $41.29 and that Part D plan's premium. But it does obviously reduce it substantially. There is a deductible of $545 total drug costs. The enrollee will pay 100% of that cost. But again, someone who's enrolled in low income subsidy or QMB does not have to pay that deductible. During the initial coverage period, the enrollee is responsible for 25% of the cost of their medications. The initial coverage period is when medication total cost is between $505 and $5,030, and these amounts change each year. There used to be this donut hole that I referred to. At least for now, that donut hole is not there anymore. The enrollee still gets a 75% discount when drug costs are between $5,030 and $8,000. So they're still essentially paying 25% of the cost of their medications when their drug prices reach that level. When drug costs go above $8,000 in the course of a year, that is considered the catastrophic coverage phase. Beneficiaries will pay either 5% as a coinsurance instead of the 25%, or they'll pay these copay amounts if they're receiving extra help. But again, the good thing about the low-income subsidy and the QMB program is that virtually all of these cost-sharing mechanisms that are built into Medicare Part D are paid for, except for these limited copays when someone has that extra help. So that's why, ensuring that someone has their low-income subsidy and QMB in place now, or even Medicaid if they qualify, having it in place now and making sure that it will be in place for the next year is a critically important part of the analysis that we do. And I mentioned earlier that people who receive the low-income subsidy or QMB are able to change their plan with a little more frequency outside of the open enrollment period. Several years ago, I think up through maybe 2018 or 2019, it used to be the case that they could change their plan any month. They could change their plan at any time in the year, and that plan change would be effective the first of the following month. That rule is now a little bit more restrictive than it used to be. For the first 3 quarters of every year, enrollees now who are in the low-income subsidy are able to change their plan once per quarter, but only once per quarter. And that plan change will be effective the first of the following month. So, as an example, Clara changes her plan from Plan A to Plan B on January 15th. She'll be enrolled in Plan B effective February 1st, but she cannot change her plan again until the following quarter, which would start on April 1st. In the 4th quarter of every year, people are only allowed a plan change between October 15th and December 7th, with that change occurring or becoming effective, I should say, on January 1st. So as an example, Clara changes plans from A to B on October 15th of 2021. She will be enrolled in Plan B effective January 1st of 2022, because that was done during the open enrollment, and the open enrollment changes are effective the first of the following year. So if Clara tries to again change her plan in this quarter outside of the open enrollment, this is example 2, let's say she tries to again change her plan on December 20th, her enrollment may appear to go through on Medicare.gov, but it's going to be rejected by Medicare. And she won't be able to change her plan again until after the new year. So, and again, if she has low income subsidy, she'll be able to change her plan again after January 1st, but that change isn't effective till the first of the following month. So that's why we want to make sure that we're doing the best we can to find the best plan for folks for next year. So hopefully they don't have to change their plan at all. But if they do, it can be a little bit of a hassle for that month of January in terms of their coverage options. Sorry, I'm having a little bit of trouble. So in terms of counseling, how do we counsel Medicare Part D enrollees? The first is we want to emphasize the importance of the low-income programs and enrollment. We want to make sure, as I've said earlier, are the LIS program and QIMB and or Medicaid, if that person qualifies, in place now? And there's a couple of different ways that you can tell. If you're able to do the personalized search for this person, and again, the vast majority of people should be able to do the personalized search through mymedicare.gov, it should indicate whether someone is receiving the full low-income subsidy or not. So that's probably the best way to check. But sometimes mymedicare.gov doesn't have the most up-to-date information. Or as we said, if you're having trouble logging into the client's mymedicare.gov, there's a couple of other things you can do to check on the status of someone's low-income subsidy or QMB. You can ask them if money is coming out of their Social Security check. If that Medicare Part B premium is coming out of their check, that's an indication that there is a problem with either their Medicaid or QMB. So that can be something to follow up on with your mentor if the person does mention that they're having money withheld from their check. If someone is paying more than that maximum LIS level copay of $11.20 for a medication, if they're being charged more than that, then that could indicate a problem with their low-income subsidy or QMB. There may be some legitimate reasons that someone is paying more. Maybe it's not a Medicare-covered drug, or it could be an off-formulary drug for that drug plan. So it's not always an indication that someone is having trouble with their low-income subsidy, but it can be. So that's also a situation in which it's a good opportunity to discuss with your mentor. Even if someone's low-income subsidy or QMB are in place now, we also want to make sure that that is continuing for 2024. And we're just going to go over a little bit how deeming of the low-income subsidy status works. This is not necessarily for QMB. This deeming only really works for the low-income subsidy program. But again, as I said, in Washington, D.C., the way that the overwhelming majority of people get the low-income subsidy is through QMB. And so in terms of making sure that someone is going to get the low-income subsidy for 2024, if someone is enrolled in QMB or Medicaid in July of 2023 or later, then they are deemed to be eligible for the low-income subsidy for all of the following year. Even if they lose their QMB or Medicaid at some point in 2024, in this example, their low-income subsidy for Medicare Part D should continue for all of 2024. Likewise, if someone is enrolled in QMB or Medicaid at any time during 2024, so even before July of 2024, then they are deemed to have the low-income subsidy for at least the rest of that calendar year. So if someone is enrolled in QMB or Medicaid in, let's say, January and February, and then they lose that coverage in March, they may have to figure out what happened to their QMB or Medicaid coverage and get that fixed. But their low-income subsidy for Medicare Part D should be in place for the rest of 2024 for that calendar year. And again, you can always identify, or I'm sorry, consult with your legal aid or your Whitman Walker mentor if you identify any problems that someone is having with their low-income subsidy with their Medicare Part D extra help. In terms of how to review Medicare Part D plan coverage for 2024, again, this first bullet point doesn't really apply because the vast majority of people are already going to have a My Medicare account. But assuming that is true, you can log in to their My Medicare account, or you can conduct the general search that we talked about if you're not able to log in. You'll review the intake form that they will have filled out or that an attorney will have filled out for them to make sure you have all of the information. You can reach out to the client or to your mentor if it's appropriate, if there's any information missing. But things that you want to make sure that you have are the low-income subsidy status. Again, that's essentially whether they have Medicaid or QMB, making sure they're actively enrolled in Medicaid or QMB. You want to have their full list of medications. And that's not just kind of the drug name, but it's the drug name, it's the dosage, it's the frequency of medications that they take. So like the absolute full name from the pill bottle, the dosage and the frequency, is it a capsule or a tablet? Some medications come in different forms. So having all of those details is very important. You'll want to know which pharmacy they are using because you will be prompted to enter their pharmacy information on mymedicare.gov. And you want to know what their current Medicare Part D, or in some cases, Medicare Advantage plan is. Again, that should pop up automatically for people in the mymedicare.gov in the personalized search of My Medicare. But for if you are in a situation where you have to do the general search, then you want to make sure that you have that information, because that will be the plan that you're comparing the others against for 2024. Will the client's plan still exist in 2024 and still be a zero premium plan? I do think one plan, and I cannot remember off the top of my head which it is, but there is one plan that was a low-income subsidy plan for 2023 that is no longer a low-income subsidy plan for 2024. I believe it's a very small copay that attaches in 2024, maybe $2 or $3. But there may be a handful of folks who are in a plan that is not going to be low-income subsidy for the next year. And as I said, is the client enrolled in a Medicare Advantage plan? And we just want to make sure if they are enrolled in a Medicare Advantage plan, in addition to doing the medication list analysis and making sure that that Advantage plan will cover those medications, there are a couple of other problems that people can have that pop up with Medicare Part C plans. As I said earlier, Medicare Part C plans are essentially a privatized version of Medicare Part A and B, and especially with that privatized version of Part B, sometimes there are doctors or providers who accept regular Medicare who may not accept a person's Medicare Part C coverage. So sometimes one problem that people might have, or they might bring up, if they're enrolled in a Medicare Advantage plan, particularly if that enrollment happened somewhat recently, is that they may have trouble seeing the doctors that they were seeing previously. So in that situation, again, that's something you can talk to your mentor about, because there might be some additional counseling that you can offer in terms of what switching out of a Medicare Advantage plan and back into traditional Medicare and a standalone Medicare Part D plan. I think there's some additional counseling you could offer on what that means for that person. Okay, so once you have entered all of that information, either through My Medicare, the personalized search, or through the general search, once you've entered the drug information, the pharmacy, once you kind of see the list of plans that are available, what are the options for 2024? You'll want to review the plan details, starting with the plan that they are currently enrolled in for 2024. What will that plan look like for them next year? Will it cover their medications? Are there any restrictions like quantity limits or prior authorizations that have popped up that might be a problem for them? Generally speaking, obviously, if people can, for a variety of reasons, I think the strongest one is convenience. People want to stay in the same plan if they can, and they may have a bias towards staying in the same plan. I think even in situations where that plan might be a few dollars more expensive over the course of the year, if it's, 20 or 30 or $50 more expensive, sometimes it's worth avoiding the hassle of switching plans to people to just stay in the plan that they are in. But again, sometimes a medication may not be covered next year, and that might be an expensive medication. Or maybe there's some restrictions that have popped up that are going to make it kind of, really inconvenient for that person. So there are some cases in which people do want to switch plans. So the factors that you want to consider as you're looking at alternative plans for 2024, you'll want to look at the out-of-pocket costs. That's going to be the monthly premium with any co-payments. And do they perhaps have any other assistance like ADAP or other ways that they can reduce their prescription drug cost? You want to look at the drug coverage for the client's current and future drug needs. are there any non-Medicare covered drugs? And I think we do have some, I think there's a memo that we send, and if not, we can make sure that we send it later, that goes through some different types of medications that Medicare does not cover. But some of those might be covered by Medicaid if someone is enrolled in Medicaid, or there may be other ways that people can get assistance with non-Medicare covered drugs. You want to double check the drug restrictions, quantity limits, and prior authorizations and step therapies. The step therapy, I think, is kind of the most onerous restriction that we typically encounter. That usually requires someone to try a different medication before the medication being sought will be approved. Sometimes you can get around that with doctor's support, but sometimes you can't. So step therapies, that is definitely something to talk to your mentor about and see if there's a way around that, or if that is a reason to switch plans. When you're in, and this is something that Jess will go over, but when you're in the Medicare.gov plan finder, you can click on the plan details. That will give you all of the information that you're trying to see around drug costs and restrictions. In terms of the star rating, that doesn't usually impact most clients' perception of the plans. I think a low star rating by itself is not a reason to recommend a plan change. But if someone does need to make a plan change, there are two essentially equal options. I could see a star rating perhaps being a tiebreaker in favor of one plan versus another. But again, it's not necessarily the most important factor to consider. So after that, the next step is going to be advice and possible enrollment in a new plan. After you finish your analysis, regardless of whether the recommendation is for that person to stay or whether you're recommending a plan change, you'll always want to check with your mentor before you finish the analysis and make a final recommendation. And of course, you can also check with your mentor with questions as you go, but you always want to check with your mentor before making a final recommendation to the client about their options for 2024. You want to print and save as a PDF the plan details for their current plan, and if a different plan is being recommended for that other plan, so there's a record of why we're recommending that switch. We'll want to highlight any concerns with the low-income subsidy, Medicaid, or QMB. Medicare Advantage, again, like I said, if someone is enrolled in Medicare Advantage, making sure they're not having trouble outside of their prescription drugs, making sure they can see their doctors and all of that is usually a good question to ask. After speaking with the mentor and kind of coming to that final recommendation, you'll discuss those options with the client. Whether or not to change a plan is ultimately a client choice. We can make a recommendation, but it's up to them whether they go through with a change, even if that is what we recommend. If you're not recommending a plan change, you can let the client know, but there's nothing to do in Medicare.gov. In order to switch plans, people have to affirmatively do that enrollment. But if someone wants to stay in their plan, assuming that that plan will continue for next year, they will automatically default into that plan for 2024, so no action is needed. You can check again with your mentor on executing the client's preferred course of action, especially if that's different. If maybe you learned something new, if the recommendation has changed, I would go back and check with the mentor again before making that final recommendation. And like I said, it used to be the case that people could change their plan any month of the year. Now those are the even for the low income subsidy folks, the restrictions are more severe on their ability to change plans throughout the year. So it's definitely very important to check with your mentor to make sure that the recommendation that we're making is the best one. And then you'll just want to document the steps that you took. And if there's any follow-up needed, that can be done after the fact, but you'll want to document the steps that you took in a closing letter to the client. So if there are a handful of situations that come up where maybe it looks like there's not a great option for 2024, maybe their current plan is going to not cover a medication or something along those lines, like their current plan is not going to be good for them, is not going to be a good fit for 2024, but you're also having trouble finding a plan that looks very much better for 2024. If the problem is high cost, there's a few ways that you can try to troubleshoot that. Are you including an excluded drug in the search? Sometimes people will bring you their whole list. Maybe they'll ask you to enter a drug that's simply not covered by Medicare. That drug might be driving up the cost, the overall cost of someone's Medicare Part D coverage. If someone gives you a name brand drug, a lot of times they're able to take a generic alternative that will be covered if the name brand is not covered. Maybe there's a pharmacy network issue. Maybe the pharmacy that they prefer to go to is not going to be a participating pharmacy next year, which can make the costs go up. So you can counsel around that issue. If no plans cover a particular medication, if there's a medication that someone needs, but no plans cover it, then you can exclude that from the analysis to give them the best advice about the remaining drugs and talk to your mentor about how to deal with the issue of that specific drug. That might include a conversation or a recommendation that the client talk to their doctor about possible alternatives to that drug. For instance, is there a substitute? Inhalers, for example, many patients are prescribed an albuterol sulfate inhaler. Ventolin is usually what's covered by these Medicare Part D plans as opposed to ProAir. If someone puts in ProAir, that can drive up the cost a lot. So assuming that someone is able to take Ventolin, that their doctor is okay with that, that's what should be used in the Medicare search. You can also, at this point, talk to your mentor about client options. And if you really do get stuck, if it seems like there's no good option for a particular medication that someone needs, I think the best thing we can do in that situation is refer them to their doctor to see if the doctor can get involved in perhaps asking for an exception, asking for the plan to cover a drug, even though it typically doesn't, or to override some kind of restriction on a covered drug. But again, you can talk to your legal aid or Whitman Walker mentor if you find yourself in that situation, because I think we have some additional, more specific advice about that process if it comes up. I think these are all still relevant, given that we are all still doing this mostly remote. It's a good idea to try to be as paperless as possible, saving things as a PDF instead of printing them out. Ask clients if they prefer to receive information by email or by regular mail. Some clients prefer not to receive a copy of the plan details, especially if they're not changing plans or it's going to have their personal information on it. They may not want that going through the mail. Sometimes a lot of clients now have email addresses, so you can send it to them that way, and that's a way to be paperless. In terms of getting in touch with clients, obviously clients like the rest of us may be reluctant to answer calls from numbers that are unknown to them. If the client has an email address, that can be a good way to reach out and let them know that you're calling to try to schedule a meeting. If you call someone and they do pick up, make sure to say that you're working with the Legal Aid Society or Whitman Walker, because I know that a lot of volunteers have worked with clients for several years in a row. But if you're calling someone that you haven't spoken to the first time, they may be familiar with the organization, even if they're not familiar with your specific name, if this is the first time that you're working with them. And this is just kind of general advice, but avoid storing the files on thumb drives, USB drives, removable hard drives, anything that could be easily lost or stolen. We want to try to keep clients' information as safe as possible. So I think that's basically it for the PowerPoint. We will contact those who registered with information on assignments and timelines. As I said, consultations and mentoring are going to be done remotely this year. And we'll take as much time and work as you can give us, but we are also here with as much mentoring support as you will need. So with that, I'm going to stop sharing my screen and turn it over to Jess. Thank you for listening.
Awesome. Thank you so much, Andrew, for that comprehensive overview. I will go ahead and share my screen. Perfect. So we've had a great overview covering, the analysis, Medicare. So now we're going to get into, going through the Medicare Plan Finder website and looking at the plans, doing the plan comparison, and going over some of the tips that Andrew has highlighted in the PowerPoint. So as you all know, in your training materials, we have this online protocol. I've taken screenshots. It's going to walk you through step by step. So you will have all of this on hand when you do your analysis as well. So don't fret. I'm going to try to go really slow just so everybody can see. I know a lot of people are familiar, but if this is your first time, just to get acclimated with the website, and the online protocol document in your training materials also walks you through this step by step. So this is the main page. I bookmarked this this particular site, the /plan compare, because if you just go to Medicare.gov, you can get here, but it's a number of clicks. So if you're doing a bunch of these, which we hope you are, which we appreciate your time, it can be a little bit more convenient just to start at this page, so you're not clicking through the Medicare.gov site. So on this plan compare page, as Andrew mentioned, you have the opportunity to log in on the left if the client already has an account. You can create a My Medicare account. The person is new to Medicare, and but that is more of a rare situation these days. If the client has forgotten their My Medicare account information, then we'll do the general search. One tip that comes up often, if you are copying and pasting from saved My Medicare account information, extra spaces that can be left when you copy and paste information will cause will give you a incorrect password or incorrect username response. So if you copy and paste and there's an extra space at the end, they will consider that a character. The website will consider that a character, and it will return. So just make sure if it's coming back, there's an error, first check to make sure there's no stray spaces in the front or the back of the username or password. That can resolve the issue. If not, you can check with the client to see if a lot of times people have changed their password. Unfortunately, working with older client populations, there are some times where clients have changed it and forgot, or changed it and lost like the piece of paper that they wrote the password down on. So do not fret. I wouldn't spend a lot of time on it. We can always do the general search. The general search will allow you to have all of the same information. You will just need to be a little bit more careful with entering the client's public benefits or Medicare Savings Program information to make sure that you are getting the most accurate costs and coverage options based on that person's public benefits. So we are going to proceed with the generic search. The big difference, they are very similar. The personalized search is just a little bit faster because you'll have the client's saved drugs already. And in this case, you'll have to manually enter all of the drugs with the generic search. So as Andrew mentioned before, we are looking for 2024 plans, which is selected here. I'm going to use Whitman Walker Pharmacy Uptown zip code, and you will use the zip code in your client's intake form. And we are always going to look for Medicare drug plan Part D. Now, as Andrew mentioned, we have a number, the Part C plans, the Advantage plans have been very aggressive with their advertising. And I think this year is the first time that over 50% of people are in Advantage plans. So if you do see this, you can check here to confirm the medication list is still accurate for the Part C plan, but we will be focusing for the most part on Part D plans. And the majority of our clients are in Medicare Part D plans. Okay, so the first screen, and we are able to confirm here, we are viewing 2024. So this is something to just check. If you're clicking back and forth between screens, you are able to see here what year you are looking for. And you can always switch back to 2023, but should not need that in this case. Here is the list that Andrew was mentioning, where you can select the person's Medicare Savings Program. If the person has QMB or QIMB, you would select Medicare Savings Program. It gives you a brief description, as we talked about. It pays for the premiums, deductibles, co-insurance, co-pays, and reduces the drug costs. If a person is a dual, as we talked about, they have full Medicaid and QMB, then we would select Medicaid. And that will show us the unique pricing for someone who also has Medicaid. And then if some benefits, then we would select SSI because they also have a unique cost based on that coding. So you will have that information in your intake. And this breakdown, as Andrew mentioned, is both in the online protocol and in the presentation. So if you're not sure which one, you can always check with your mentor. But if it's only QMB, we select Medicare Savings. If it's QMB and Medicaid, Medicaid or SSI. So we're going to say this person, our hypothetical person here, is a dual. So they have QMB and Medicaid. So that means we're going to select Medicaid as their help with costs. And we will select next to proceed to search preferences. We always want to see the drug cost in this instance. We are comparing plan costs, so we will always select yes here. And now we get to the drug, adding the drug screen. So we're going to run through a couple of common drugs here just to highlight some things that you'll see in your process. So one thing to know, and we're going to start with metformin, which is a common drug for our clients. So on your intake form, on your list of drugs, a lot of times it will say, the drug name by itself, like metformin, or it will say metformin HCl, which is hydrochloride. So you would want from this list, and it'll always auto-populate a list of forms of that medication for you. As you see here, there is a metformin hydrochloride. So if anything is that drug name HCl, you want to find the hydrochloride option to make sure it's accurate. If it's HCTZ, that's hydrochlorothiazide, and that will also come in as a separate option. So these are different compounds of that medication. That's why it's really important to make sure you're entering that information, the name fully. And so we can add the drug, and then it's going to take us to the dosing information. So this information that comes up here is a common or standard dosing for this medication. A lot of clients will have the standard dosing. So that's a great place to start, but you want to make sure you're referring to your drug list for accuracy. This is very important when we get into quantity limits and other restrictions the plans might have. So we're going to say that the individual has this standard 1,000 milligram tablet, 60, which means 2 pills every day per month. As you can see here, there is a list of other forms of this medication. You will see the HCl-ER, which is extended release tablet. So if someone has metformin HCl-ER, you want to select this option because that extended release tablet is a different form of the medication than the non-extended release. And obviously an extended release would be typically a 24-hour. So it should only be 1 per day for most people. But that can depend on, each individual situation. So just an example of when you put the medication in, you put the entire name in, it's going to give you all the different options for that, that they have in the system for that medication. So we will stick with the standard 2 1,000 milligram tablets per day, 30 days. So we're going to add that to our drug list. Now we started our drug list and we'll add another drug. So the next drug we'll add is a common antiretroviral for those living with HIV, which is Biktarvy. And as you see, as I type it in, it's going to give me options. We have Biktarvy here. We're going to add to our drug list. And most of the antiretrovirals will have this 5225, some kind of compound, because they're a compound of a couple antiretrovirals. There typically is only 1 or 2 versions of the antiretroviral. So you see there's only 2 options here in comparison to the metformin. And typically they're taken 1 per day. So that's pretty straightforward. And we will add to our drug list. So we'll do 2 more. The next one we'll try is vitamin B12. And as you see here, vitamin B12 does come up in the prescription drug list. But as we know, Andrew already discussed that there are excluded drugs, that Medicare excludes certain drugs from its formulary. You have that list as number 6 in your training materials of excluded drugs. And what we see the most of those excluded drugs are over-the-counter. So aspirin, low-dose ibuprofen, symptomatic cough suppressants, like cold and flu type medications, and vitamins. The other last one that I'll talk about is, and we'll discuss a little bit later, is erectile dysfunction or sexual health medications like Viagra, Cialis, also a lot of times seen as sildenafil, which can throw people off, which is the generic version of those. Those are largely not going to be covered. There are very few instances where there are folks that take those drugs that are coded as erectile dysfunction drugs for heart health issues. But in most cases, it's not going to be covered, and it's going to really mess up your plan analysis because it's going to drive the cost up. So that's something, if someone has sildenafil, Cialis, Viagra, you'll leave that off of your analysis to make sure you get an accurate comparison. So as you see, we put in vitamin B12. That's obviously a vitamin. It should not be covered, but it comes up in the Medicare formulary. A lot of other things, if it's like vitamin C, you won't have, some vitamins won't even come up. If you try to search it, there will be no option because it's just not covered. So in this situation, there is a vitamin B12 that comes up in the system, but you see there's only one type of vitamin B12, and that is a solution. So most likely your client has a tablet, certain number of vitamin B12 pills a month. This, however, is a vitamin B12 injection. As you can see, it comes in a vial, and it's a liquid. And so this can be administered for folks who need it by their doctor. So if the client has a vitamin in B12 injection that they do with their doctor, that is very rare. That would be the only time typically a vitamin would be covered. So because we don't see our tablet as it would be listed in our drug list, we are going to cancel and not add this to our drug list. So again, but will not mess up our plan finder results. So the last thing we'll add is the client's inhaler. Now, as Andrew mentioned, Ventolin is the type of inhaler that is covered by most Medicare Part D plans. And as you see, when I typed it in, it gave us the option to choose the generic version albuterol. Now, this is you'll get this pop-up screen anytime you enter a brand name drug into the system. It's gonna offer you the chance to use the generic instead. Our standard would be to use the generic version. For basically almost all drugs, there are a couple of exceptions, and the albuterol inhaler is the most common. The albuterol inhaler, for some reason, the generic is just not covered by the plans. It is more expensive. So the brand name we will choose in this one instance. So in this instance, we'll say keep brand, but for most other drugs, you will say add generic. So we're going to keep the brand name Ventolin. This is the standard dosing. You're going to want to make sure if it's albuterol, if it's ProAir, you want to make sure that you're checking the dosing every time to make sure it is accurate. There's only one type of dosing for the Ventolin. And then you have the 18 milligram inhaler option. So we're going to say one inhaler per month and then add to our drug list. So now we have our complete drug list here because the B12 we have removed, and we are ready to proceed with to add our pharmacy. So scroll to the bottom of the page. If you need to go back, if you forgot a drug, you can always add another drug here. And sometimes the client will say, oh yeah, I forgot I had this one. So you can always go back and add more drugs to your analysis. And then when you're done adding drugs, and we will move on to adding the pharmacy. So you can choose up to 5 pharmacies. I will start in this instance with Whitman Walker Pharmacy. And so we've entered 2009 as the client, 20009. It has the client zip code where they live. And when we type in the pharmacy name to save time, we have our 14th Street location pop up. So we can add that pharmacy. And you will see that that pharmacy has been added at the bottom of the page here. So we're also going to say that this client has a second pharmacy, and some clients have multiple pharmacies for various reasons. Oftentimes I hear of clients that say, I like to pick up my HIV or other discretionary medication at a pharmacy that's not in my neighborhood, where I'm not going to run into my neighbors or coworkers or something like that. So it's important to capture all of the pharmacies listed because clients might pick up different medications at different pharmacies for a variety of reasons. So we're going to add Alpha People. which is a specialty pharmacy in our right around the corner from our 1525 location on 14th Street. And we'll see it has populated here. And we can add this pharmacy as well. And you see we have them both now listed at the bottom. You can add up to 5 to your analysis. If you type the name in and you're not seeing it, you can also change the distance up to 25 miles. That allows you to not have to go back and search and search and search, and should hopefully pull up the location. And we are ready to proceed. So we'll click done here in the corner once we've selected our 2 pharmacies. And now we will be taken to the plan results. And so as Andrew mentioned, and most of our clients will have LIS. They will have 0 premium plans, and their cost generally should be fairly low. The one LIS plan from last year that is discontinued is Humana Basic. So Humana Basic will be, I believe it's $3.10 for the premium. Ideally, we would want to get someone out of Humana Basic and into one of the 4 LIS plans so they are not having to pay a monthly premium. I know it's $3 a month, and obviously this is a client choice. I recommend it because clients who have LIS typically are just not used to paying anything for the premium. So if they stay in Humana Basic, that means next year they're going to get a bill, and it's going to be for like $9.30. It'll be billed for the quarter, and a lot of times people don't open it, or they think it's junk, or they forget to pay it, and then they can create issues with their premium. So ideally, if someone has LIS, we're getting them out of the Humana Basic. If they love Humana Basic, if they had it for 20 years and they don't want to change and they'll pay the invoice, that's fine. If they want to keep it, totally up to them. As we said, it's their choice. But I would explain to them, you're going to have the invoice, it's going to come, you're going to have to pay it. It's money that you could save, but if you really like it, you can stay in it if it still covers your drugs. So the 4 LIS plans for this year are SilverScript Choice, WellCare Classic, Cigna Secure, and ClearSpring Health Value. As you can see, we have a plan that's not LIS that comes up second on this list. It has a monthly premium, and that is because this page is sorted by lowest drug and premium cost, which is our standard plan sort that we want to use to make sure we're capturing that LIS pricing. Of course, even though the total is $100 for this plan with the monthly premium, and this is $101 per year, we still would want to get the client in the LIS plan, ClearSpring Health Value, that does not have a monthly premium. So be mindful when you see the monthly premium here, you're always going to want to go for the 4 0 premium plans if the client has LIS. And so if you have the personalized search open, there will be noted the first time that comes up is the client's existing plan. So if for this example, if the person had SilverScript Choice this year, it would say your next plan, and it would say SilverScript Choice. It would be highlighted in green to say, this is what you're going to have for 2024. Below that, you would then scroll to see, are there any plans that are cheaper? Now, when we say cheaper, I'm going to go back to what Andrew said. Changing, so if the client's in ClearSpring Health Value next year, and it's going to be estimated $101 of cost, and SilverScript Choice is available at $74, that's not enough money that we would suggest of savings that we would suggest the client switch plans. As Andrew mentioned, it is really challenging for folks to change their plans. That means they have to wait for a new card in the mail. That means they have to tell all their pharmacists about their new plan details. It can be a lot of upheaval for folks. So a $25, $30, although that is an important amount of money for our clients, typically we're not going to suggest a change unless something is not covered, unless their pharmacy is out of network. And you can typically tell that something is not covered or the pharmacy is out of network because this cost will be in the tens of thousands of dollars. So it's very noticeable when something is not covered. So let's look at SilverScript Choice because it's coming up as our cheapest option at $74. So we'll click the plan details. And all of the things, all of the pricing, pharmacy information, all of your information is going to be in these plan details. So we're going to need to the mentors are going to need to receive the plan details of the current plan. And you can use this print option, print to PDF. But we definitely need to see the plan details for the current plan. Most people will not be switching plans, which is great. So we'll just need that. But if you recommend that the person switches plans, then we'll also need you to print the PDF of the recommended plan so that we can review both of these. So we can see here at the beginning, it says covers 3 of 3 drugs. So we know already all drugs are covered, no monthly premium. It's looking good. Showing no drug deductible, as we talked about with LIS plans. And we see here, both of these pharmacies are in network. Now, sometimes a pharmacy will also say preferred in network with a marker here. A preferred in network pharmacy oftentimes means that clients will receive $0 copays for simple medications, commonly prescribed low-cost medications. So there can be benefits to a preferred in network when a plan is preferred in network for the person's preferred pharmacy. As we see here, the prices are fairly comparable. And when we're looking at the copay costs, it's just a reminder that these costs are estimates. So this is in Medicare's estimate of what this pharmacy is going to charge. I've heard of a number of clients who have gone to a pharmacy like Alpha People's for years, and they say, oh, they don't even charge me that amount. They charge me less than that. Or, you know, some other variety. Oh, the pharmacy offers a deal on this or that. So this is an estimate. We go off the estimate, but this is another reason why if it's $25 difference, that's not a reason, $50 difference to switch the plan, because the client might not actually experience that exact saving at the pharmacy due to the estimation of the copay cost. So we have the total annual estimate here. We have the estimate for each drug breakdown. So you have all of the details. And here is a month-by-month breakdown. So I think this breakdown is really helpful for clients to see this is what my estimated total copay cost if I fill all medications per month. So I can expect in January, it's going to be the highest. And then as I hit catastrophic coverage, you see in May, if the client fills all of their medications, they'll hit catastrophic in May, and they will have no copays for the rest of the year. This often happens with clients who have antiretroviral drugs for their HIV or other types of specialty drugs that are really high market value. They'll hit that $8,000 mark a lot earlier than others. Now, another point that I will go back to, just scroll up here with the Biktarvy. So we see the annual estimate of the Biktarvy. For a client that is living with HIV, if they're under 500% of the poverty level, they're eligible for the AIDS drug assistance programs in the area, also called ADAP. And ADAP will pay the copay costs in these first couple of months. So all of these copay costs in here, that is Biktarvy, ADAP will pay that copay. Now, it's really important to distinguish that ADAP will pay the copay of a covered drug. So if the person's Part D plan pays for the Biktarvy, the copay cost that is left over, ADAP will then cover that copay. And there are a number of drugs on the ADAP formulary. There's like antibiotics, there's a number of drugs, and those formularies are also in your materials, so you have them as a reference point. But if you're seeing, you know, the client has LIS, but they have like 15 drugs and it's a lot of copay costs, ADAP, if they are actively enrolled January 1, will cover the copays for anything on the ADAP formulary, as long as it is also covered by their Part D plan. If the Part D plan is not covering the drug, ADAP will not then cover the full market cost of that drug. They're only covering the copay. If someone in the scenario that Andrew mentioned earlier, where they are not eligible for LIS, but they're living with HIV and they're eligible for ADAP, ADAP can also pay their Part D monthly premium. So they will need to send that invoice of their Part D monthly premium of their non-LIS plan to ADAP. ADAP will pay that, and ADAP will then also pay the copay. So it's another great program to assist with those copay costs. Most folks with ARVs are going to hit catastrophic, so they're not going to have copays in the latter part of the year, but that calculation renews each year. So people are always going to have, and I think they're always surprised by their copays in January, because they're like, I haven't paid copays for 8 months. What are you talking about? but every year that calculation restarts with catastrophic coverage, so they will in January. So it's important if folks are ADAP eligible that they are getting enrolled and they have that copay assistance in the beginning of the year. Okay, as we scroll down the plan here, we have the option to have the breakdown for each pharmacy, which is great. And you'll see retail costs. This is why we get to 8,000 very quickly. And we have, the cost before deductible, after deductible. For those with LIS, we're not going to have a deductible, so we're not as concerned. And then if we select view more drug coverage at the bottom, this is telling you, general plan percentages, but what we're really here for is this section, other drug information. So this is where we're going to see where the drug restrictions are. So as you're going through the plan analysis, you want to click through, open all these boxes to review, and make sure that you are looking, we are verifying for the plans this section. As we talked about, prior authorizations, quantity limits, and step therapy are the main restrictions. If a plan has step therapy for a medication, we probably don't want to select it if there are other plans available that maybe have just the prior authorization. Prior authorizations are somewhat common, and the client would reach out to their medical provider to complete the Part D plans form to request a prior authorization for the drug because it's medically necessary. If a client is in an existing plan with a prior authorization and they've been in it for years, most likely that's already been done with the plan and doesn't need to be done again. But if the client is switching to a new plan and has a prior authorization, their doctor will likely have to do that in the new year with the new plan. So the formulary or the prior authorization is requested based on the plan, not based on the year. So if they're already in the plan, they should be good, but if they're switching to a plan with a prior authorization, they need to reach out to their provider to complete that. In terms of quantity limits, this is another really important. If someone takes one pill a day, they're going to be within the quantity limits. That's somebody we don't have to worry about. You're really going to be concerned when somebody takes 3 or 4 pills a day, or needs multiple lotions or multiple vials of drops. And so when you can find your quantity limits of the plan here, you'll click the yes button. So this tells us Biktarvy does not have quantity limits, and that is because it is 1 pill a day. That is the prescription for it, so it's not going over. And then we see here, we do have quantity limits for the metformin and the inhaler. So when we click yes here, we see that the client can have up to 75 of these 1,000 milligram tablets per month. And we can see here that our client has 60. Our client has 60, so we are within those quantity limits. And for the inhaler, the client can have 36 inhalers within 30 days. So obviously with our 1 inhaler, we are within the quantity limits. So in this case, we're all set within the quantity limits, no step therapy, and no prior authorization. If you are comparing plans with comparable costs, we would want the plan that has the least amount of restrictions as sort of a tiebreaker. If there's step therapy, we want to avoid that at all costs if possible. And again, we have the star ratings here. It's not a reason to switch plans, as Andrew mentioned, but if it's 2 LAS plans and they're exactly the same and you're like, what should I pick? Maybe the star rating is a good tiebreaker, but that would be the only reason for that. And another option, so another point that Andrew brought up is if the client has an excluded drug and no plans cover that drug. That often happens with like new drugs or specialty versions of a drug that have recently come out. And a lot of times those drug manufacturers will have patient assistance programs where they will offer people a certain amount of money, or they'll cover that medication for the person for the first year or however many years, because it's new and they know people are not covering it, and that allows folks to try new medications. There's also the opportunity for a formulary exception. So if someone absolutely has to take a medication and nobody covers it, their provider can try to request from the plan a formulary exception. And again, this is all information to talk about with your mentor, but it basically there are a number of options for folks in these instances. And I can stop sharing my screen But the last thing I'll add is if you do find a better plan and you talk with your mentor, they review both the current plan details and the recommended plan details, they advise that you switch, you call the client, you get their consent to enroll. When you do the enrollment at the bottom of the page, then you will need to print the enrollment confirmation page. And that's absolutely critical and vital that we have that enrollment confirmation page printed to PDF, because it has their confirmation number if something goes wrong with the application or it's not processed properly. It also has the plan number for the client to call if they do not receive their new Part D card in the mail. And it's also our proof, obviously, that you were able to complete the enrollment. So very important. We need the plan details printed. We need the enrollment confirmation printed. If the client stays in the same plan, just the plan details, nothing else needs to happen on the website. The client doesn't need to do anything else. They're good to go for the next year. And I will stop sharing my screen.
Thanks so much, Jess. I see that we've had several questions come in while you and Andrew were speaking. If we can go through those, and if anyone has additional questions, we can go through those as well. What are the dates for the Medicare Part D quarters?
I'll be happy to take the first one. So I believe this is asking in terms of the first 3 quarters of the year, what are the dates that someone can change their plan? So it's really just kind of a quarter system. So the first quarter would be January, February, and March. The second quarter would be March, April, May. The third quarter is going to be June, July, August. And then the last portion of the year is related to the open season. So at any time within each of those individual quarters, people are allowed to change their plan one time, and it is effective the following month. But then once they've done that, and this is again assuming that someone is LIS or Quimby and has the right to make this plan change outside the open enrollment, once they've done that, they are essentially locked into that plan at the very least until the next quarter begins.
Right. So September would be the last month that you could make a plan based on the LIS special enrollment period, a plan change. Otherwise, it has to be during open enrollment season effective January 1, unless it's something else like the person is new to Medicare in November. So they don't have Medicare. Obviously, they can enroll in November and they will have coverage active in November. If you have a case like that, obviously you'll discuss with your mentor, but for the purposes of our general analysis, we are looking for plans that will begin January 1st, 2024. And I see the question here about QMB. So as Andrew mentioned, and you can see in the chart, so QMB and the LIS coverage that comes from that means that there are 0 premium plans available, LIS plans available, and capped copay costs. So in that range of costs of copays that are in the slides. Of course, someone with LIS can choose a plan that has a premium. That premium will still be reduced because of the QMB and LIS coverage. So there's an opportunity to have a premium plan, but you will still have the reduced cost from LIS. So that's also why we want to get folks into those 4 LIS plans to take the most advantage of those savings. And in regard, to Medicare coverage in general, essentially when a client has QMB, they're not allowed to receive a bill. So even if Medicare pays and QMB pays and there's some amount left over for covered services, clients are not allowed to be balance billed by law. So if they get a bill, they can essentially call that billing department and say, I have QMB, run it again, and that bill will be eradicated. So it's an incredibly valuable program. It essentially means no medical cost for covered services, but you will have capped copays for the Part D with QMB coverage, regardless of donut hole and everything else.
I'll take the next question from Eric at Legal Aid, appearing as Sylvia in the Q&A. Is it realistic for an enrollee to change their Medicare Part D plan on the last day of the month and expect to be enrolled in the plan the first day of the next month? Is there a cutoff for when changes are processed? So, I mean, I think that's a practical question. I mean, I think that in theory, it should work that way, although there may be a delay. To the extent that someone wants to change their plan kind of in one of the first 3 quarters and have it be effective the following month, it is certainly better to do that earlier in the month rather than later. I think, if it's sort of an emergency, hopefully this will have come up at the beginning of the month when someone realized there's a medication they can't get. And it would be good to reach out and try to do it before the last day. I mean, I think in terms of, and I think this also goes back to what Jess was saying about printing the enrollment confirmation. If you're in a situation, if it were to come up, and it shouldn't come up during the open season, during the open enrollment, but, if at some point this were going to come up sort of later down the road or whatever, where someone were, in a situation where they had to enroll in the last day of the month or in the last few days of the month, printing that enrollment request confirmation would be very important in that situation. I think the way it would probably play out is that it may take a little bit of time for that enrollment to go through, but then it should be retroactive to the first of the following month. So I do think it would work out, but especially for the first part of the next month when the plan change should go into effect, there could very well be like some administrative hiccups in terms of actually getting medication. So the best thing to do is try to get something like that done earlier if time permits.
I will add to that, in those instances, if a client comes to you at the end of the month because they just realized, I always advise the client to fill anything they have that can be filled under their current coverage, because I see typically a 10-day processing. So if you submit it like the last day of the month, it's not going to show in the system for about 10 days. So during that time, it can be tricky because technically the other coverage has ended, but because the new coverage is still processing, it can be kind of a no man's land in terms of the prescription refill. So I always tell folks, like, go to the pharmacy today, go tomorrow, if tomorrow's the end of the month, to make sure that you fill whatever you have. So, and a lot of times clients will have prescriptions for 3 months, so they don't necessarily need to fill something within 10 days, but if that's the case, they should fill it with the old coverage if possible. And then they'll have to wait at least 10 days to see their new coverage process. And then they'll also have to wait for the new card of the new coverage to come in the mail, which also takes about 2 weeks. If the person has a My Medicare account, they can actually go into the My Medicare account and see that new card once the application is processed, and print out a little temporary card that at least has like the BIN and other information that the pharmacy would need to fill if they're waiting for that card to come in the mail. But always, as Andrew said, always better to do it at the beginning of the month to avoid all of that tricky chaos.
And I will say that's actually one of the advantages of mymedicare.gov. If someone is having trouble enrolling and they find themselves in this position, another thing they can do is call their new plan. And at least they can ask for the numbers and literally just write down the BIN number, the PCN number, the account number, and take that to the pharmacy. And that should work. So the old technology of a phone can come in handy every now and then too. I'll just take the next question from Jonathan. I think that's pretty quick. Assuming a client has My Medicare login information, are we supposed to use that information to log into the system on their behalf? And yes, that's the idea. That's why you'll be presented or given that information from the entity that's assigning the case to you, whether that's Legal Aid or Whitman Walker. Excuse me. And that's how you will log in and hopefully do that personalized search that does make this process a little bit easier. So yes, that's how you'll access their information.
Awesome. Okay, so I'll take this next one. So we should not be comparing Part C plans as an option. That is somewhat outside of the scope of what our open enrollment analysis is, particularly because a lot of the plans are HMO, and whether or not they're HMO or not, they could be PPO and still not be taken by that client's provider. So the client would have to take all of the plans to their providers and say, which one of these do you accept? So that is a whole other process outside of what we're doing. I will say there are some special needs plans for folks who are duals or have QMB. and they offer some additional perks. I think some offer like a little over-the-counter drug money, like a $50 per month for you to get, vitamins or aspirin. Some offer like maybe a gym membership and like very minimal dental benefits. But if a client is a dual and also has Medicaid, there really aren't any more perks that you would get by having that dual plan, because Medicaid is going to offer that same minimal dental coverage, and it's also going to cover those over the counter. So if someone's a dual, there's really not a need for the Part C plan, for that special needs plan, and not everyone accepts them. So that can be more challenging, because clients typically want to stick with their providers, especially if they have specialists that they've gone to for like cancer or neuro or orthopedic, something like major medical issues. They're likely not going to want to change those specialists due to the insurance. So original Medicare, especially in the DC area, is widely accepted. That is not true everywhere, but in DC, original Medicare is widely accepted. So I would say there's not really an advantage for the Advantage plans, although they are marketed heavily. If you've seen the commercials already on television, they are marketed heavily to folks. There is not much of an advantage for our low-income clients.
So I'll take the next question. And it kind of, there is the question from Sylvia, and then 2 questions down from anonymous attendee about asking how involved the mentors are. I think they sort of go together. So when you are assigned a client to work with, you will also be given your mentor's contact information, phone number, and email. And I think, you can reach out whatever the best way for you is. If you give us a call and leave us a voicemail, we'll get back to you. If you email, we can set up a time to talk. In terms of how involved the mentor is, I think that really depends on just sort of how much assistance the attorney who's working on the case needs. I know a lot of folks have done this for many years and feel kind of very comfortable taking these cases and running with them. For the new folks, you may want to have a kind of an initial discussion with the mentor. Okay, you've now gotten this case. Can we just go over the next steps for this individual person? What is that going to look like? We'll be happy to have those conversations as well. And then, we're here to answer questions as they pop up. Again, if you're getting the drug list together and you're having trouble finding a particular drug, or it looks like someone's taking a drug that's not covered, or you're, just sort of whatever issue that you may be having as you're doing the analysis, please reach out to your mentors, at those points as well. But then you'll definitely have another kind of structured conversation with your mentor once you've done the analysis, once you kind of have that final recommendation ready. Is this person going to be okay to stay in their plan? Or is it going to be better for them to switch to a different plan for 2024? You'll definitely want to have that conversation, run through everything with your mentor before kind of taking the final steps of either making that recommendation to stay or doing the enrollment through mymedicare.gov and confirming everything. But essentially, I think we're here as much as needed on an individual basis, is what I would say.
And
I can jump in. Oh, go ahead.
well, I was going to follow what Andrew just said for the next question. This is all an analysis and mentor checking in on your analysis prior to contacting the client. So I think as we've seen, you're clicking through, it's a lot to read and double check to have someone also on the line with you. So you're going to want to do the analysis, contact your mentor with your recommendations, or contact your mentor with questions, talk through all of that, have your final plan and your approved either recommendation for a new plan or approved to stay in the same plan. And then you're going to want to contact the client with your final analysis. You might find out in that call, the client says, and this happens, oh, I forgot I have 2 new medications that I didn't tell you all about. And so you'll say, okay, let me add those and redo the analysis to confirm this is still accurate, and then I'll call you back. I would not do it on the phone just because it can take time, and then you're trying to talk, and I think it's better to say, okay, let me review that, because you might find that there's errors, and then you can talk with your mentor. So you might need to, redo that analysis, but I wouldn't do it while the client's on the phone. Oh, sorry, go ahead, Sylvia.
No, it's okay. 2 things I want to point out, I think, are when it comes to reaching out to the client, one pitfall that we see often is folks delaying. So I realize that, and we're going to talk about this in a little bit, the process for legal aid and the process for Whitman Walker is different. Whitman Walker does 2-week cycles in which people are assigned their clients, and you have that timeline. It's still 2 weeks, right, Lee? It's 2 weeks to complete that analysis and submit your work to our to Whitman Walker staff. On the other hand, on the other hand, legal aid has it so that you're assigned your client and you have 4 weeks to complete your assigned time. But what I normally see as the pitfall when there is one is that folks will look at it and say, I've got 2 weeks, and then they'll delay. And then by the time that they're reaching out to the client, it becomes very close to the deadline. And then there is a rushed process, and then you are reaching out to the mentor who they have their own caseload and may not be able to respond as promptly as your deadline may be. So if there's one takeaway from just past experience, I will tell you, please reach out to your clients as soon as you get them so that you are able to introduce yourselves, explain your role, who you're working with, so that at least they know you, they're expecting your call, and they can begin sharing information with you. So that's the process about the tip about not delaying. And then, of course, the mentorship, as we talk about it, we have very different processes. We have different processes, we have different timelines for our organizations. What we have in common is that you will be receiving support throughout this. And when you are looking to change a plan, we encourage you to check in with the mentor to make sure that you're not doing that too hastily without having checked in with somebody to make sure it's the right choice. But one other thing is that, as I talk about different processes, you all registered via Zoom. Everyone who registered will receive information on next steps from our respective organizations. For legal aid, I can tell you that you'll receive your client assignments by October 23rd, and then you'll be expected to have those analyses completed by November 22nd. But I encourage you, we will reach out to you. We will tell you what the next steps are. And of course, you'll know what deadlines and what you're signing up for.
So I see the last question about insulin. I actually don't know offhand the answer to that question. My assumption is yes, but I think to the extent that insulin is covered through any types of insulin that are covered through Medicare Part D, for our clients, they should be capped in what they're paying in terms of copay by the low income subsidy in QMB. So I believe that's the case. Jess, do you have any more information on that?
It is still capped at $35 a month, as we saw last year. So they are continuing. So cost of a 1 month supply of Part D or Part B covered insulin is capped at $35 per month.
Well, if we have no further questions, no further questions, I think we can call it a day. Thank you so much for joining us, for volunteering your time with us. Thank you, Jess and Andrew, for leading us yet again through another training on Medicare Part D. If you have questions after you have received your assignments, please reach out to the person who had sent you that, whether it is Lee or whether it is me. Otherwise, I simply say thank you, and I hope you have a wonderful day.
Thank you,
Thanks,
everyone.
everyone.
Bye.